Okay, this last section we are going to talk very briefly on evaluating the vestibular system. Chapter 23 is pretty much fully dedicated to evaluating dizziness and vestibular problems, and we're just going to briefly touch on it because as PTAs we are not obviously doing the evaluation, but we have to be able to read an evaluation and know what went on in there. So patients reporting dizziness are often describing different experiences. So dizziness is a pretty vague thing that can include a lot of different symptoms. So the clinician has to distinguish among vertigo, which is that illusion of movement, near syncope, which is you feel like you're going to faint, disequilibrium, which is a loss of balance, and lightheadedness, which is sort of an inability to concentrate or focus. Differential diagnoses are important because the causes and the treatments are different. So really it's up to the evaluating therapist to decide whether it's something that can be treated in PT or whether it can't, or whether we can do remediation as with BPPV, or we're having to work on compensatory strategies. So to differentiate vestibular from cerebellar and sensory ataxia, there's a set of criteria for each one. So sensory testing can be used to localize a vestibular lesion. Hearing, proprioception, and vibration are tested. So impaired proprioception can cause unsteadiness. So proprioception and vibration tests are used to distinguish between lesions of the conscious proprioception pathways and vestibular lesions. So they're narrowing it down basically. So sensory testing is a big part of the evaluation. There are specialty clinic testing for vestibular ocular reflexes. You can test it either by rapid passive head turns. So you're actually holding the person's head and turning it back and forth. You can test dynamic visual acuity, so you have like a vision testing chart and they're moving their head and you're asking them to read off things from the chart. There is an apparatus that uses a rotating chair. Caloric testing is another apparatus, and then the electron nystigmography. That is a hard word to say. So basically you're specifically looking for nystagmus. So some of the things, we have a VOR testing apparatus in our clinic that the patient's looking at a computer screen basically, and you're asking them to do different tasks, moving their head while keeping focused on certain things. And you get it compares to standard response times, so you can test their vestibular ocular reflexes. Actually, when I look at that screen, it really makes me nauseous, so I try to stand behind the screen if somebody's using it. But so that can be one of the symptoms of diminished VOR is nausea when you're trying to look at these things. There's different treatment for different VOR treatment where you're focusing on something that's not moving and you're moving your head, or you're holding your head still and you're looking at something that is moving. So rehabilitation doesn't directly affect central dysfunction of the vestibular system, and it's ineffective for Meniere's disease. So even though rehabilitation can be really effective for peripheral disorders, for central disorders, you're usually working on compensatory strategies. It's effective for BPPV, unilateral vestibular loss or dysfunction, bilateral vestibular loss, and central vestibular disorders that benefit from movement retraining. So again, there's some things we can treat and some things we can't. Exercises are designed to promote movement retraining, habituation, or substitution to improve function. So in movement retraining, we're practicing and modifying movements. So we're doing balance training, we're doing the different types of movement training that we do in other areas of PT. Habituation is exposure to positions or movements that produce symptoms, followed by relaxation until the symptoms abate. So a lot of the times we'll teach someone a movement that produces their symptoms, and then we instruct them to wait until they've had a full minute or full 30 seconds without symptoms, and then they do it again. So we're trying to habituate to that movement. So you provoke the symptoms, you wait till they go away, and then you provoke them again. It's not always everybody's favorite type of treatment because you have to provoke your symptoms. Substitution is using alternative sensory inputs or motor responses, or using predictive or anticipatory strategies. So that is the thing where you're using you're relying more on your other symptoms. You're relying more on your vision or your proprioception. It's the same theory behind someone with vision loss using other sensory inputs to guide their movement. So either they're using a cane, so they're feeling what is what is in front of them, or I had talked about in the vision section, working with someone with vision loss in the pool, so they're using the proprioceptive information that they're getting from the water. So that's the type of strategies that we use in vestibular rehabilitation.